So this is a thorny problem for lots of people. It's easy if the patient is obviously normal. It's easy, to a certain extent, if they've got glaucoma. But it's what about these people that are borderline? So I hope over the course of the next 15 minutes to be able to give you some help in making that decision. So why are people glaucoma suspects? Well, it could be because they've just got raised pressure, or because of their disc or nerve fiber layer appearance, or because they've got a visual field that looks a bit glaucomatous, or because they've got suspicious angles, or they've got a strong family history of glaucoma, or they've got risk factors for glaucoma, but they don't seem to have any glaucoma at this point in time. So we have 6 scenarios, and I'm going to work through each one of these in order. So what about just elevated IOP? Well, this could be an isolated finding on one occasion. It could be that it's confirmed over time as being formerly ocular hypertension. It may be an association with a narrow angle, but everything else is normal. And it could be with additional related pathology. So we have to split this scenario into 4 groups. So let's look at the first of those. If it's an isolated finding, you need to take a careful history and examination to make sure that the patient hasn't been doing something unusual with that eye. If it's one eye, know that the normal asymmetry range does vary with the tonometer that you're using, and non-contact tonometry, you can have an asymmetry of up to 8 millimeters of mercury between the 2 eyes on a single examination. That's not just with one pulse, that's with an average of 4 pulses, particularly if that's the first time the patient has been examined with that technique. We showed this 20 years ago in, again, another epidemiological study. Look for other signs. The patient may have forgotten that they've had an injury to that eye in the past. Look for subtle pseudoexfoliation pigment dispersion. Consider that it might be a measurement error. It depends whether you've measured it or somebody else has measured it, and I'm going to talk a lot about measurement error in IOP this afternoon, and relate your pressure reading to the central corneal thickness and the hysteresis, if you have that facility. Again, more about that this afternoon. But all things being equal, if you've got a pressure over 35 millimeters of mercury in the absence of any other findings on a single occasion, it's reasonable to treat. What about confirmed ocular hypertension? Well, what are you trying to do? You're trying to prevent conversion to glaucoma. Remember that the main bit of evidence we've got from this comes from the ocular hypertension treatment trial, where they lowered IOP by an average of 23% for 6 years, and it halved the risk of conversion. But we need to consider more than that. We need to consider the risk factors. What is the level of the pressure? How old's the patient? Do they have myopia, family history? All of these other things that come into it nowadays, which were not really considered by Oates. In the UK, we have an organization called NICE, the National Institute of Clinical Excellence, which gives us guidance on things. And they've produced guidance on when to treat ocular hypertension. And it's a very simple algorithm, but it has cutoffs. Your central corneal thickness, they have specific cutoffs for it. Well, what do you do if it's 554? You know, it's not as simple as that, and we should be using more than simple knee-jerk algorithms, particularly in the modern era. So when to treat in ocular hypertension is an art, not a science, really. It depends on your ability to monitor that patient and how often you can do it. It depends on which healthcare system you're working in, whether you have the facility to do it or not. Try to make the decision with the patient rather than just yourself. Don't make the treatment worse than the condition, particularly the diagnosis, because all treatments have their side effects, and they're not always just physical. They may be mental. May turn the patient into a depressive by giving them a diagnosis about an eye condition that they don't really have a major problem with. So, important points. Unless the pressure is over 30, it's reasonable to observe with modern equipment, because that should detect a change before the patient would have converted, as they would have done in Oates. It's rare to go from true ocular hypertension to significant visual loss in 20 years if the patient's under observation. And treatment does not eliminate the conversion to glaucoma. How about with a narrow angle? Well, you need to ask about subacute attacks. You need to check for peripheral anterior synechia, all of the standard things that you do in a patient. You can consider a trial of a single 2% pilocarpine drop to see how much the pressure drops. That's useful. Consider a prone darkroom test, which I'll talk about a bit more later. And if a cataract is present and you're going to take it out, lower the pressure medically, remove the cataract, and check the pressure carefully follows surgery, and you may well be able to stop the drops. How about with additional related pathology? Well, in PDS, remember that pressure fluctuations are commoner than in OHT. There's a higher conversion rate to pigmentary glaucoma than OHT to POAG, and of course the pressure can normalize with time as it burns itself out. And there is no proven benefit from YAG-PI at any stage in this condition, according to the 2016 Cochrane review. In pseudoexfoliation, again, the pressure fluctuations are more common than ocular hypertension. The angle can vary in an individual patient because of laxity of the zonules, and conversion to glaucoma is much more common. It's twice the conversion rate at the same pressure and central corneal thickness. So what about if you have an abnormal disc or nerve fiber layer appearance? Well, this can be with normal pressures and fields, with raised pressure, or with a suspicious field. So with normal pressures and fields, is it early normal tension glaucoma you're looking at here? You need to know your normal range of discs and retinal nerve fiber layer appearances, and think of the signs of early normal tension glaucoma, as I mentioned in my previous talk. Now here's an example of a highish myope with an OCT scans which look suspicious, but in fact, is it glaucoma or is it just normal for a high myope? And we did one of the first studies on high myopia with OCT scanning, and here is this patient's purple chart showing the normal range for a high myope. So in fact, if you plot it against the normal range in the machine, it's abnormal, but if you plot it against the normal range for that group of patients, it's completely normal. They didn't have glaucoma. So you need to examine for a significant asymmetry of the disc and look at cup size, as I said before. A 10-degree field can really be useful, as I'll show in a minute. And if in doubt, well, it's not desperate. Observe with sequential measurements to determine if any change is occurring. Remember, glaucoma is all about progression. It's about change. And with modern machines, we can document change very well nowadays compared with the old days, providing you keep it on the same machine. How about with raised pressure and a suspicious field? Well, that would lower the threshold for treatment at any intraocular pressure, really. For a suspicious field, don't forget the causes of field artifacts. Remember that there may be other causes of field loss. Check the color vision. Color vision should be normal in glaucoma, providing there isn't a congenital reason for it. And check the nerve fiber layer against the disc to see if there's any real correlates. And again, this 10-degree field. So here's a patient that sort of looks, as you look at this part of the field, as though it's normal, but if you look at the whole field, there are definitely statistical abnormalities occurring there in the lower charts. And when you do a 10-degree field, you find this patient has an obvious arcuate defect superiorly. And of course, when you put that with the disc, you'll all say, well, there are the lamina corrosa pores. You can put it all together. But if you hadn't been able to see the disc very well because of a bit of cataract maybe, or you just hadn't been able to look at the patient that easily, then you can always do a 10-degree field. It's really useful for certain types of glaucoma. So what about suspicious angles, which is always difficult? Well, we've discussed the raised IOP bit with suspicious angles already, but what about with normal pressures? And we get a lot of patients sent to us in the UK with just narrow angles, as our optometrists have got OCT scanners. What are you trying to do? You're trying to prevent acute angle closure, and this is proven in fellow eyes of patients who've had acute angle closure in the other eye. Then a PI is almost mandatory, unless they're very asymmetrical anterior chambers. And should asymptomatic patients suspects have PI? Well, that's the question. Or what are you trying to do? Well, the other thing you're trying to do is prevent chronic angle closure. Those are the two things that can happen in narrow angles. So there is no randomized control to guide us yet on patients who just have narrow angles but nothing else. The ZAP study currently being performed may help us in Asians, but there isn't really an equivalent of it going on in Caucasians. So we have to think about what are the risk factors for angle closure and put the whole thing together with our patient. So if I'm going to jump off my fence, what would I say? Well, those with a central AC depth of less than 2.4 millimeters, because true angle closure that is correctable by a PI, so I don't mean other causes of angle closure like plateau iris, have a shallow central AC depth. less than 2.4. It's extremely rare to get angle closure glaucoma that's not plateau iris with a central AC depth of 2.4 or above. If you have an 180 degrees of oppositional angle closure and one or more of these, a positive prone darkroom test, which I think is still a really useful test, particularly if it's positive. It's not always positive in patients who are going to get angle closure, but if you've got it, it's helpful to give you an indication to treat the patient. If they have a strong family history of angle closure glaucoma, those who can't seek emergency eye care routinely if they're out in the middle of nowhere and they can't get to somewhere if they have an angle closure attack, and those who need to have drugs which we know increases the risk of angle closure. And that's what I use, and it seems to have served me well. If there's a family history of glaucoma, it just lowers the threshold for treatment in all of your scenarios in terms of the open angles, particularly if relatives went blind from glaucoma. Remember, the lifetime risk of open-angle glaucoma in siblings of patients with glaucoma is actually 25%. We did a longitudinal study to show that some time ago now. So how about other risk factors for glaucoma without any features of glaucoma? Does just having pseudoexfoliation increase your risk factor for glaucoma? The answer is probably yes. Pigment dispersion syndrome converts to glaucoma more commonly in males, so you're going to have a slightly lower threshold for treating your male patients than your female patients. And if you have angle recession, then 180 degrees and over is a significant risk factor for future glaucoma. So there, briefly, over the course of about 12 minutes, by the look of it, I've covered, hopefully, when you should treat glaucoma suspects. And remember that it's not a clear yes or no in every patient. You have to use all of your medical skills that you've learned over your years as a medical student and as an ophthalmologist to balance the decision for that particular patient, not follow a standard cookbook like the NICE guidelines that are produced for the UK. Sorry, NICE guidelines. Thank you.